Madam Chair, Kathy Rapp, Chairman Dan Frankel, and members of the committee, thanks for the opportunity to present testimony concerning fetal development and public policy. I've been invited to address the topic of fetal development from the perspective of a board-certified obstetrician gynecologist, of course, whose primary concern is the safety and well-being of all my patients and all patients. My comments are limited to my personal experience and opinions.
Excuse me, doctor, could you bring your microphone just a little closer?
Thank you.
Thank you.
Opinions in regard to my specialty. I practice obstetrics and gynecology in King of Prussia, Pennsylvania, and have 33 years in practice with the treatment of low and high-risk pregnancies in general gynecology in the hospital in which I was delivered, which is Bryn Mawr Hospital. And specifically, I'd like to testify to the issues of fetal pain, viability to increasingly earlier gestational ages, and best practices in the case of obstetric emergencies. First, I'd like to tell you that I am pleased that I made the trip up here to hear the testimony of all the other doctors, all four of them. It was an educational experience. Their testimony was honest and true, and I appreciate their opinions, and I do appreciate the information they gave us. I'm hoping that you have my testimony before you, but with your privilege, I'd like to have the license of sort of bouncing on it up and down like a trampoline instead of just reading from it.
I don't believe we have it, so you're welcome to.
With respect to pain, it's a very complex subject. Pain is the provision that we have that has been given to us from our nervous system that tells us that something's wrong. It's a protective mechanism that signals that there's tissue that's being damaged. Everybody knows what it's like to sit on a tack, put their hand in the fire, withdraw it. It's been given to us so that we can help ourselves and save ourselves from difficult situations. But it's not just a mere component of nervous connections that exist between some parts of your body and your cortex, through the spinal column, through the thalamus, and to the cerebral cortex. There's a lot of emotional aspects to pain. People respond to pain in many, many different ways. Women that I've seen in labor sometimes sail through it without an epidural, and some can't tolerate one contraction. Soldiers that have had amputations, traumatic amputations in the heat of battle, don't even feel their arm being blown off. So there's an emotional component. I'm not so sure you can use animal studies in order to determine whether a human fetus feels pain. I'm not sure that animals have the same emotions that fetuses do. So it's a very, very difficult subject, and something that you really can't take a look on comparative anatomy with an animal and apply it to a human being. So that being said, it's difficult, but you can look at pain in two different segments. You have the physiologic pain, which is the noxious stimuli that's applied to tissue that causes you to feel this unpleasant sensation, and then you have the emotional response to that pain, which comes over a period of history of you having experienced pain or been in painful situations. So it's very, very difficult. But we do know one thing. We do know that babies develop, and they develop on a course toward when they leave fetal life and become newborns. And then newborns turn into toddlers, and toddler turns into teenagers, and then you have 21-year-olds like me who really experiences pain. But that being said, and not to inject levity into the conversation, the point is that these studies that tell you that the cortex has to be connected to everything else in order for something to feel pain is old information. I mean, everybody knows now that it precedes 25 weeks, that the cortical subplate actually can send signals to the cortex so that you can feel pain before 25 weeks. Now, do we know exactly when that's going to happen? No. So the information we have on 25-weekers not feeling pain, as it was, which is old information, is based on opinion. It's based on comparative anatomy with animals and looking at how animals developed and looking at what type of, how they respond to stimuli. But as scientists, that's not how we make decisions. We make decisions based on empiric evidence, not conjecture. I mean, we all know that. We've seen drugs being tested and tested and tested, equipment being tested and tested. It hypothetically goes through a process of proving that something is either harmful or it's beneficial. And we all experience this in the development of the coronavirus vaccine, albeit it was accelerated, but it was tested and tested and tested. So we knew that it was going to be safe when it was going to be delivered to the public. So that being said, we can't test a baby. There's no way you can test a fetus. So what do? You go along with the principle of non nocere, which is above all do no harm, the non-maleficence that we share as physicians, that we take every day when we're talking to patients, that if we're going to do something, we don't want to do something that's going to hurt them. We want to keep it safe, and we want to deliver an appropriate treatment for the disease or the problem that they have. I've delivered many babies between 22 and 20, well, earlier than that, but I've delivered many babies between 22 and 25 weeks that have gone into the neonatal intensive care unit. I met my wife because she's a neonatal intensive care practitioner. And I go and visit these babies that are 23 weeks and 2 days or 23 weeks and 3 days as they're starting IVs and they're starting scalp lines on them, and as they're putting UV lines, and as they're caring for them. These babies feel real pain. They respond in the way that anybody here in this room would respond to pain, by withdrawing, by grimacing, and sometimes by crying when they're old enough to do that, or they don't have an endotracheal tube in. These are things that we see all day long. We have objective evidence of extrauterine 23-weekers that are feeling pain. And to assume that a 23-weeker inside the uterus is any different than the 23-weeker that's outside of the uterus is ludicrous. But there are times when we, as physicians, and we as parents even, administer pain that's beneficial. Now, just indulge me for a second, because I want to create a situation that I searched through my memory banks to give you an analogy. On October 14th, 1987, when I was a senior resident at Hahnemann University Hospital, a little baby by the name of Jessa McClure fell down a well that was only 8 inches wide. And she was 18 months old. And I don't know if you remember, but they called it Baby Jessica. She was 22 feet down in a small 8-inch well, and they hurt her down there. In fact, she was down there so long she started singing songs to herself. They dug a hole all the way down next to the well, broke into the well, and they called an obstetrician because they couldn't get her out. And the obstetrician wanted to go down and take care of her, but he couldn't. They wouldn't let her. So they sent the emergency medical guy down, and they said, listen, take all this lubrication down, and I want you to lube her up as much as possible, and I want you to pull as hard as you possibly can, and if she cries and screams, don't stop pulling, even if something comes off. And that's what they did, and they saved her. The point being is, there are things that we do in medicine and in this situation that are painful, but there's a benefit on the other side. They saved her life. These small babies that are being aborted have nothing to look forward to. There is no upside to them. Their last moments of life are extremely painful. You heard how it's done. An extraction abortion is done with sharp instruments where they dilate the cervix and go in, start pulling off pieces of the baby until they think they have the whole thing. Then they put the suction curette to get the placenta, and then they put all the parts together that they made sure that everything came out. And that's what's happening. And these babies experience pain. Now, do I have objective evidence of that? I can assume that if a 23-weeker outside the uterus feels pain, then a 23-weeker inside the uterus is going to feel pain. So, what should we do? We should, above all, do no harm. We should know that these babies feel pain. And this is a terrible, terrible thing we're doing. So let me direct my attention to viability in the early gestational ages of viability. So at the same time the medical community is learning more about fetal pain, we as physicians are having access to moving viability ages. It used to be when I was in my residency that you were happy to send a 26 or 27 weeker to the neonatal intensive care unit because that was probably the age where the baby wasn't going to have a lot of, it was going to survive and it wasn't going to have a lot of physical or mental disabilities. It's getting lower and lower and lower. In fact, at Bryn Mawr Hospital, the age where they offer neonatal support is 23 weeks and 0 days. Now that's where they'll go to the family because it's recommended at 25, and it's offered at 23. But how do you hear about these stories about 21 weekers and 22 weekers that are surviving in the neonatal intensive care unit? Well, I think it comes down to dating gestations. If you date a gestation based on an early ultrasound that comes out, say at 7 weeks, the standard deviation of error of an ultrasound at any gestational age is 8%. So that if you have an ultrasound that's done at 7 weeks, and 7 times 7 is 49, 8% of 49 is probably 4. That means that the standard deviation of error on calculating that gestational age, if the mom did not know her last menstrual period, is somewhere 4 days greater or 4 days less than 7 weeks. But if you wait to 20 weeks and you do an ultrasound, and that's the only ultrasound you have to date that pregnancy because the mom has avoided prenatal care, has not gone to anybody, and she says, I don't know when my period is, let me do an ultrasound and figure it out. If you look at the 8% rule for a 20-weeker, then you could have a baby somewhere between 19 weeks and 6 days and 21 weeks and 4 days. But if you look at a 22-weeker, it could be as old as 23 weeks and 4 days. And that's how possibly a 24-weeker ends up in the neonatal intensive care unit and doing well. But absent that, you know, we're getting to a point in medicine where we're developing artificial placentae, plural placenta. Placentas that where we can actually hook babies up that are born significantly premature in order to sustain their life until they get to the point that they can actually maintain life in the neonatal intensive care unit in the traditional ways. So viability is changing. If we're crafting law, are we crafting law just by what we know science to be or what really is existing the way that it should be, the way that babies can be in the future? And this is what we're doing. So when you pick a gestational age and say you can't do an abortion, you know, after 24 weeks, at 23 weeks, that baby lives in the neonatal intensive care unit. And then I just want to address my attention to one other thing, and that is that Pennsylvania law permits abortions up to 24 weeks gestation and even allows abortions later in pregnancy where necessary to protect the mother's life or protect against a significant irreversible impairment of the mother's basic bodily function. There are few, as a practicing obstetrician gynecologist, I don't sacrifice my patients to my own personal views with respect to abortion. I have had women who have had significant morbidities coming into the pregnancy or approaching certain gestational ages where I know that terminating the pregnancy is the only way that's going to save her. People that have had significant preeclampsia where their blood pressure is uncontrolled, they're 21, 22 weeks pregnant, they've already seized, and you know if you don't have the time to induce them, right? Doing a hysterotomy and delivering the baby through a large incision that is not going to survive is not the appropriate thing to do. And the only thing to do is offer the opportunity to go down and do, under anesthesia, where the baby is protected, a extraction abortion to save her life. I've had patients like this, and those are recommendations that I offer her. So I'm not oblivious to the need for certain things. But as we approach ages of viability, and we have women with medical emergencies, or I should say obstetric emergencies, where those babies can survive beyond 23 weeks, beyond 22 and a half weeks, and we have the privilege of being able to induce their labors and allow them to deliver vaginally, or take them to a cesarean section and deliver those babies by cesarean section so that baby can be presented to the neonatal intensive care unit to live, is options that I've used many, many times. Now, look, as obstetrician gynecologists, we all terminate pregnancies, all of us, and we do it all day long. It's called an induction of labor. You have someone that's a week and a half overdue, you bring them in, you start some medicine, you deliver their baby. So the first thing I say to my patients after they deliver is your pregnancy's over. You're no longer pregnant, we've terminated your pregnancy, now you have your baby. So we all do this. There are times when we terminate pregnancies at 23, 24, 25 weeks in a way that saves the baby, that saves the mother. And if I could just comment on one thing, it's been my personal experience that I've never had anybody, not one patient, regret either delivering a very, very premature baby that went to the neonatal intensive care unit and has problems, or a baby that wanted to be induced at 20 weeks, obviously before the age of viability, and delivered her baby and held that baby. I have never had one complaint in an argument to what Dr. Beck said. Never one had a person complain. She has closure, she held her baby, she never regrets. The only regrets I see are the people who didn't do that, the people who terminated their pregnancies. Now, not all of them regret, but if you look at the ones that regret who terminated versus the ones who regret who didn't terminate their pregnancy, I've never had one regret. So that being said, make sure I didn't miss anything. I thank the committee for the opportunity to testify today. I call upon lawmakers to consider this knowledge and perspective in evaluating how to best and serve pregnant women and unborn children in the Commonwealth. Thank you.